To diagnose syphilis, we need to understand several things: individual, population, or community risk factors for exposure to T. pallidum, clinical signs and symptoms concerning for syphilis, interpretation of syphilis test results, and previous syphilis treatment history. In this video, we will focus on obtaining and interpreting syphilis test results. This video was created by the Denver Prevention Training Center and the National Network of STI Clinical Prevention Training Centers in partnership with the Denver Sexual Health Clinic. To diagnose syphilis, a combination of tests are needed. These tests fall into two categories: non-treponemal and treponemal. Non-treponemal tests, for example, the RPR or VDRL, detect antibodies to lipoidal antigens like cardiolipin, which are present during syphilis infection. However, these tests can also be reactive in the setting of other conditions that cause tissue damage, so confirmatory testing is necessary. Treponemal tests, for example, the EIA or CIA, detect antibodies specific to T. pallidum. These antibodies usually persist for life, so a positive test result indicates current or past infection, so confirmatory tests are necessary. There are two testing algorithms. The traditional one starts with a non-treponemal test, while the reverse algorithm begins with a treponemal test. Large organizations often prefer the reverse algorithm for its efficiency in processing large volumes. It doesn't matter which algorithm you use. What's most important is that your organization has reflex testing built into the protocol, so that you don't need to put in new orders for confirmatory testing or make the patient come back for another test. Let's walk through each algorithm, starting with the traditional algorithm. It begins with a non-treponemal test, the RPR or VDRL. If it's non-reactive, syphilis is unlikely. However, the RPR can be negative in 30% of early syphilis cases. If there are signs and symptoms of syphilis during your clinical assessment in a patient at increased risk for syphilis, consider presumptive treatment. If the RPR or VDRL is reactive, next, obtain a quantitative result, which in this case is a titer. Note that this test measures immune activity in response to the infection, but does not tell us how much T. pallidum is in the body. Once we have our RPR or VDRL titer, next we do a confirmatory test with the treponemal test. If the treponemal test is negative, but the RPR is positive, it's likely a false positive, and syphilis is unlikely. If the treponemal test is positive and the RPR is also positive, this indicates either previously treated or untreated syphilis. If untreated, treat immediately. For those with a prior history of syphilis, compare their current titer to the last titer you have on record. A fourfold increase suggests a new infection needing treatment, while a fourfold decrease with no new symptoms indicates a past infection. Let's walk through the reverse algorithm. Start with a treponemal test, EIA or CIA. If this test is non-reactive, it means syphilis is unlikely. However, it can take a few weeks between exposure and development of antibodies. So if there's a known exposure to syphilis, or there are exam findings consistent with primary/secondary syphilis, then consider treating presumptively. If the CIA or EIA is reactive, do a confirmatory non-treponemal test, either the RPR or VDRL. If the confirmatory test is positive, meaning both your treponemal and non-treponemal tests are positive, this indicates previously treated or untreated syphilis. Both the clinical assessment and sexual history will determine if this is a new or old infection. If the negative confirmatory test, RPR or VDRL, is negative, meaning you have a positive treponemal test and a negative non-treponemal test, do a tiebreaker test with another type of treponemal test, for example, a TPPA or a syphilis IgG. If the second treponemal test is negative, meaning you have 2 out of 3 tests that are negative, then syphilis is unlikely. If the second treponemal test is positive, meaning you have 2 out of 3 tests that are positive, this indicates previously treated or untreated syphilis. Clinical assessment and history will help determine which it is. Let's do a knowledge check. Question 1. Which of the following best describes the difference between non-treponemal and treponemal tests for syphilis? A. Non-treponemal tests detect T. pallidum antibodies, while treponemal tests detect lipoidal or nonspecific antibodies. B. Non-treponemal tests detect lipoidal or nonspecific antibodies, while treponemal tests detect T. pallidum specific antibodies. C. Non-treponemal tests are always more accurate than treponemal tests. D. Treponemal tests can only detect current infections, while non-treponemal tests detect past infections. The correct answer is B. Non-treponemal tests detect lipoidal or nonspecific antibodies, while treponemal tests detect T. pallidum specific antibodies. Non-treponemal tests detect antibodies to lipoidal antigens like cardiolipin, which are nonspecific antigens, and these are present during any type of infection, including syphilis. Whereas treponemal tests, EIA or CIA, detect antibodies specific to T. pallidum, the bacteria that causes syphilis. Question 2. True or false? A positive treponemal test always indicates current syphilis infection that requires immediate treatment. The correct answer is false. A positive treponemal test indicates either current or past syphilis infection. Treponemal antibodies usually persist for life, so a positive result alone cannot distinguish between an active infection and a previously treated one. Clinical assessment, history, and non-treponemal test results are necessary to determine if treatment is needed. If you get all the questions correct, excellent job! If you missed a question, don't be discouraged. We recommend reviewing the video again or the resources below for better understanding. Learning is a journey, so keep exploring. Thank you for joining us for comprehensive diagnostic assessment for syphilis, tests, staging, and best practices. In upcoming videos, we will cover the clinical assessment, treatment, prevention strategies, important resources, and more. Let's continue learning together.